Welcome to Big Butts, No Lies. I'm Mavi, your go-to guide for everything plastic surgery. With 18 years in the industry working alongside top board-certified plastic surgeons, I know what really goes down: the good, the bad, and the botched. Now I work for you, bringing you real, unbiased info to help you make the best choices for your dream look. Whether you're going for subtle enhancements or a full-on transformation, I'm here to give you the facts, the tips, and the confidence to navigate your surgery journey. Let's get into it. Should be fun. Hey guys, do I have the episode for you today? I promised you that I was going to bring you plastic surgeons from across the country who could do amazing procedures for you. And today I have one from Florida. Not the Florida that y'all are thinking about, but actual nice board certified plastic surgeon, Dr. Leo Baccaro, and he is in Naples, Florida. Hi, thank you for being on the show.
Hi, Mavi. Thank you. Thanks for having me on.
I'm super excited to have you on. And you guys don't know, we were just having an amazing conversation off air. And what we're going to be talking about today is a procedure that has been hot, hot, hot. Everybody's talking about it. Everybody's doing it. And that is a hybrid breast procedure. It could be a breast lift, breast augmentation, but why don't you tell us a little bit about what even is a hybrid breast procedure?
So, hybrid breast procedure or hybrid breast augmentation kind of refers to the fact that you're using implants to augment or to enhance the breast, but you're also using fat transfer. Now, it's slightly more complex than that. Obviously, there's a couple more components to the procedure, but the hybrid comes from that, using implants and fat to really kind of achieve more elevated results than you would be able to otherwise with using implants alone. It's great, and the way I explain it to patients is fat, which you can liposuction from different parts of the body, can be used as a tool for contouring, and we know that with BBLs, with fat transfer to the face, and now we're using it quite significantly with fat transfer to the breasts. And it's really just to address a lot of different kind of concerns, cosmetic concerns, uh, that are very typical with breast surgery. And as you mentioned, it could be used with breast augmentation, with a breast lift, sometimes breast revisions if patients already have implants. There's a lot of things that it can be used for, and it's really safe and very effective. And it's really, honestly, it's changed my practice dramatically over the past couple of years.
And on this show, we love a good fat transfer. So, so uh, usually with fat transfers, women think about a fat transfer and they're thinking about BBLs. But fat transfer can be used in so many different ways: in your face, in your hands, in your breast, in your buttocks, pretty much anywhere that needs a little bit of refilling, it's a good option. So, how do you decide when a patient comes to you that they would be a good candidate for a hybrid?
Well, I would say the very first thing I need to know is if they have enough fat, right? So some patients are very, very thin and they just don't have enough fat to give. But I would say most patients have at least a little bit. And usually the inner thighs is where I like to get the fat from the most, or sometimes the lower back. But from kind of more anatomical standpoint, I'll use the example of just primary breast augmentations. I would say, anywhere from 80 and 90% of patients are actually good candidates. Anybody or most patients coming in for an augmentation, a lot of times the issues we see when we're first analyzing that kind of initial anatomy is that obviously the breasts are a little bit smaller than what they want to be, but where do those breasts sit on the chest, right? Some women have breasts that sit somewhat close together, some further apart. Some have a lot of volume in the cleavage area, some have very little volume in the cleavage area. And in general, when you're doing a breast augmentation, you can only, when designing the pocket, you can only place that implant so close to the midline without causing a problem. I'm not sure if you talked about in other episodes, but one of the things you really want to avoid in a breast augmentation is having the pockets run into each other and then getting a problem called symastia, where it just looks really terrible. You should have that sternal skin stay down. And so there's certain limitations when you're trying to get an implant as close as you can to the midline to develop cleavage. Some women's breasts just sit too far and wide apart, and no matter how much you try, you're still going to have a gap there. And that's one of the main areas, I should say, where fat transfer comes into play, because you can gain a couple of millimeters on each side of the cleavage and bring in those cleavage lines, what we call the cleavage lines, and this kind of aesthetic, drop that we should see from the top of the breast to the bottom of the breast and the cleavage. uh, you can bring that in quite significantly with just small volumes of fat. It's very different than the buttocks where you're using large volumes. Here you're using generally smaller volumes of fat, which is very safe and effective. The fat itself also has other kind of utilities, right? It's good for contouring the breast if you want to get a more rounded cleavage, right, as opposed to like an inverted V. It's very helpful if somebody is wanting larger implants but want to maintain a somewhat more natural appearance. A very typical problem is if somebody is very thin and they have a very large implant or a very projecting implant, it may look very, quote unquote fake, and they may or may not want that. So the reason it looks fake is because there's a step off, between the chest wall and the breast implant. And if you can fill in that step off and create a smoother transition, it looks a lot more natural, even though it may be on the larger side. And the other thing that's very typical, and I think 99% of women have it, is breast asymmetry. Pretty much every single woman, or almost every single woman, will have some volume discrepancies between the breasts. And you can use fat transfer to transfer a little bit more fat on the smaller side to try to even things out. And you can really do some fantastic work in that sense, and not only rely on asymmetric implants, right? Implants are a different size on each side.
You brought up a really good point that often see, and I don't think we've ever talked about it. So you brought up the the space in between the implants,
Yes.
and one of the things that I've heard over and over and over again is, oh, this surgeon's before and afters, like their implants are too far apart, or this surgeon's before and afters, like their implants are too close together. And then when I go look at the before and afters, or they'll send me a page and it's not the surgeon's work. It's actually like the patient's anatomy is they have a wider space between the breasts. So I want to talk a little bit about that because it's something that I hear so much about, that space in between their breasts and how they don't want them too close together. They don't want them too far apart, but it's their anatomy.
Yeah, it's their anatomy. It's like it's exactly that. You don't want them too far apart, but at the same time, you don't want them so close together. And patients can be somewhat variable with that. Some women will tell me they really like that close volume of cleavage, and some women will say, please make sure that there is a space there. In general, I think that we as plastic surgeons try to follow certain aesthetic concepts. And one of the concepts that I find is that there should be a space between the breasts. That space, that skin needs to stay attached to the sternum. There needs to be a discrepancy in height between the sternum and the takeoff of the breast and that breast projection. The way I measure it is because I've measured my finger, it should be one finger breadth in between the breasts. And so when I do my initial markings in surgery, I measure out how much it should be. Now, the reality is you're always going to be somewhat constrained by the baseline anatomy. If someone has a very, very wide set base width, or the breasts sit very wide set, you may have limitations and you may not be able to get the entirety of that volume, but you can still do quite a bit between the implant pocket and doing the fat transfer. And I think it really does make a difference. You can get some very, very nice results in patients who have very little breast volume and have somewhat of wide set breasts.
One of the things that I saw on actually an article that was written about you, or that you wrote, was that you are doing the fat grafting breast implant and a internal bra. So let's talk a little bit about that, because as you know, it's probably one of your hottest topics. Women want that internal support, but there's also a lot of questions about it.
The internal bra. So in primary breast augmentations or breast augmentations in lift, we use, I use something that we kind of call a internal bra. Now, an internal bra can be used as a name for a variety of things. Sometimes it's a mesh, sometimes it's a stitch. For primary breast augmentations, it's an internal bra stitch. So basically, with normal breast anatomy, you have the breast tissue, and right underneath, you have what's called the inframammary fold. So it's the fold that lives right underneath the breast that gives the breast that shape, right? That fold is a very, very important structure. And in the way here in the US, where we're taught how to do breast augmentations in a very classic way that hasn't changed for a long time. And during those teachings, which is very similar in the majority of the country, essentially you're taught to ignore that structure. And what that leads to is, for example, using larger sized implants because you know they're going to quote unquote drop, right? But the issue is if you don't control that structure, that IMF is what we call it, inframammary fold. You're leaving up to chance what's going to happen with that fold. Is it going to stretch below? Is it going to stay too high? Are you going to go below and then create what's called a double bubble? A lot of potential issues if you don't address it. And so, what an internal bra stitch is, it's a special barb stitch that I use that basically you run that stitch along the bottom and you really secure that fold where you want it to be. And it acts like a sort of internal wire, internal bra. And it doesn't allow that implant to go further past that point. It'll stretch a little, but it doesn't allow it to go past that point. If you allow implants to drop, they drop down and they drop out, right? And so your cleavage becomes wide, and the only way to achieve cleavage is with a bra, right? If you create a good pocket, and the hybrid breast augmentation has several components like we talked about, one of them being an internal bra. If you create a sturdy pocket with a sturdy internal bra on the inside that to support the bottom, against gravity, then instead of allowing the implants to drop down and out, they're going to get pushed up and in. And so when you're standing in a neutral position, it should look like you have a bra on, right? And this is the whole concept of, why do we do all this is you have to go back to thinking, well, why do women want a breast augmentation in the first place? And the real reason is they want to look good in clothing, right? In the clothing, out of clothing, but they want to be able to use certain clothing. And for example, here in Florida, it's warm all year round. It's very typical to use clothing that requires you not wear a bra, a low plunging neckline, an open back, or a bikini without a lot of support. And you want the breast to look good in that clothing, right? And so the whole reason behind this hybrid breast augmentation is to have braless cleavage, right? Braless cleavage. And so that's where the internal bra is that second component that's really important in the hybrid augmentation.
One of the things that I've seen happen, and we've never talked about it on the show, but I think we should, is bottoming out because I feel like what you're talking about might prevent bottoming out.
For
So
sure.
what is bottoming out? Why does it happen? And how do you prevent that?
So whenever you place an implant, the implant, because of gravity and because of muscle forces, is going to tend to want to get pushed downwards, right? And that's what we say, they've fallen into position and they've gone and now they've settled. They always start very high and then things stretch out and they settle into their position. What happens is that inframammary fold structure can stretch, and sometimes you can actually surgically damage it so that it separates from the chest wall and it's no longer adherent. And you can get situations where the implant just sits too low. And when the breast volume of an implant sits too low, what happens is it rotates the nipple position and makes the nipple position look like it's pointing up, right? And so what you've done is you've stretched out the distance between the nipple and the fold, and that's what's called bottoming out. There's another concept, it's called a double bubble. If you have a very strong inframammary fold and the implant pushes behind it, you're going to have a fold where the implant is, and you're going to have a fold where your old fold was. And so it looks like you have two folds at the bottom of the breast. And so it's two different things that can happen if you're not paying attention to that inframammary fold and doing everything you can to avoid it. Now, will an internal bra avoid it 100% of the time? No, but it definitely, and I don't know if I have statistical data on this, but from an anecdotal standpoint, from a practical standpoint, my own practice changed quite significantly when I started doing this hybrid technique, where it's much more rare to get any bottoming out or implants that sit too low. So yeah, that's what bottoming out is, and definitely reinforcing that structure, that inframemory fold, really decreases the rate of malposition of the implant that's too low, which is a bottoming out.
So if somebody who's listening and who has maybe implants that are sitting too low on their chest, or they are dealing with a bottomed out implant, would they be able to come in to see you and for you to put that implant back where it's supposed to be?
Yeah, absolutely. In fact, probably one of the things I do most in my practice is breast implant revision. So I'm in Naples, Florida, and I don't know if people know a lot about Naples, Florida, but there are a lot of patients here in town that already have implants and have had implants for 20, 30 years. So I do perform a lot of breast implant revisions. Now, the reason for bottoming out is not solely a lack of structure of the fold or lack of support. It's not the only reason. One of the other reasons is how the implant is placed underneath the muscle in a submuscular pocket, which is common and I use very often. In fact, most of the time I'm doing a submuscular pocket. But that is actually the third component of the hybrid breast augmentation is how you put the implant underneath the pocket, right? So classically speaking, again, we're taught how to make a pocket in a certain way underneath the muscle. You can divide the muscle more or less, and you can separate the muscle from the breast tissue, performing something that's called a dual plane, right? And we're classically taught to do a dual plane in a very specific way, in a very linear fashion. And what happens is when you do it that way, you lose a lot of support on the lateral portion of the breast, the side of the breast. Whereas with the hybrid breast augmentation, the dual plane that you do, which is the separation between the muscle and the breast tissue, is done in a curvilinear fashion, right? And you can cant the muscle however you'd like in order to use the muscle to push the implant where you want it to go. So some people need the implant pushed more in, some people need the implant pushed more down, and a small minority of patients may actually need the implant pushed outwards, like people that have a pectus excavatum. If you're worried that those implants are just going to drop into this kind of divot into the center of the chest where the sternum is, you can do what's called a lateral dual plane to help push them out. So if the muscle is too high and canted up like this, it does not matter how much you try to tighten the pocket or push the skin in or whatever, you're going to fail because the muscle chronically is pushing and stretching that skin on the lower portion of the breast. So not only do you have to repair that fold underneath the pocket, you actually have to, in many cases, identify where that muscle is. And the vast majority of the time, it's because that muscle is too high. You have to grab it and pull it down to give support to the lateral breast.
So interesting. I
Yeah.
love hearing all of this. So I what I'm hearing is that you do a lot of breast revision surgery.
Hmm. Yes.
So with breast revision surgery, what that means is somebody has already had some sort of breast procedure, whether that be a breast augmentation or a breast lift or a breast reduction. And unfortunately, there are a lot of patients walking around out there who are dealing with situations with their breast that they're not happy with. One of the things that we were talking about off air was something that is happening in our industry where there's a certain subset of surgeons who are doing procedures like breast augmentation and breast lifts. And I think because of that, we're seeing a lot more breast revision surgery. Um, I've actually spoken about this recently on another episode where I had a client who came to me who was very unhappy with her breast, and she had a breast augmentation, but in reality, when I saw her immediately, I was like, well, it's because you really needed a lift. This wasn't the right procedure for you. So when somebody comes into your office, how do you help them understand which procedure is the right one for them? For example, if they're coming in for breast, they think they want an augmentation, but really they're a good candidate for a lift.
So I think that's a great question. I think there's good and bad things about having so much information online, right? You see a lot of things, and a lot of the information is very good, and some of it it's a little bit more, some of it a little less accurate. But the problem with that is you may not be able to identify what information is really most pertinent to you, right? When I get patients, I'll use the example of do you need an augmentation? Do you need a lift? Do you need a lift with an augmentation? I just really have a frank conversation with patients, and I ask them first is like, okay, what are your concerns, and what are you trying to achieve? And after doing the physical exam, I explain to them. I say, look, you know, you're going to need a specific type of surgery to achieve whatever result you want. Now, sometimes it's very common. People have what they want, but they also have ideas about what they don't want, right? So a very typical example is somebody who may need a lift. They say, I don't want the scars of a lift. Okay. They say, well, if you use a larger implant, you would be able to fill out that breast tissue and potentially not need a lift. Or you may we may be able to have the implant sit a little bit lower and be a little larger. You're going to lose cleavage. Your nipple position is going to be lower, but you won't have the scars of a lift. But I'm very frank and honest with them, and I tell them, look, if are you going to be happy with larger implants that sit lower and are further apart? And a lot of times they'll tell me, no, I want the hybrid look. I want the cleavage and the braless cleavage and everything. And I tell them, unfortunately, I cannot achieve that if I don't do a lift. So I'm a very big proponent of giving people as much information as possible to make good decisions for themselves, right? Um, Not everybody that comes in with similar complaints or similar concerns will leave the office with the same options. That, like I said, there are some things people want, but there's definitely things that people don't want. So it's my goal to kind of go through their options, say what is the expectation with any given option, and letting them decide for themselves what is the best option for them. And just explaining things as really as frank as possible, because at the end of the day, um, I may have a vision or an aesthetic of what I think would be best for them. But if they tell me it's a absolute no, I don't want the scars from a lift, then don't do a lift, right? Because once you have scars, you can't undo scars, right? They're there forever, whether they heal well or not. They're there forever, and you never want to commit somebody to a permanent result that you know they didn't want in the first place. So that's important. The communication is really key.
That was something that I saw on our preparation chat that communication between the surgeon and the patient has to be very clear. And I always encourage my girls who are listening to tell your surgeon everything exactly how you feel. Don't be shy. Don't be embarrassed to say anything. I promise you, they've probably already heard it before.
You've heard all sorts of things.
Every
Uh, it's perfect. It's completely true. It's completely true. At the end of the day, what we really want is we want patients to be happy, right? We want patients to be happy with what they've chosen for themselves and the results that they're getting. It's very easy as a plastic surgeon to just say, hey, everything's going to be fantastic. We'll do this, and this. You're going to love it. And then it's not what you told them it would be. They're going to be upset with good reason, right? With good reason, because it's my responsibility to make sure that they have a good understanding of what they're getting into. So, if you're clear and you're honest with patients and you tell them, look, if you don't want to do all of this, we may have a reasonable result doing something less, but the expectation should be we're not going to get 100% of the result you're going for. We may get 75, 80% of that result you're going for, but whatever, maybe we didn't do the scars that you didn't want, right? And so they have that option is that would I rather be more maximalistic and do everything and have scars and reach 100% of what I was trying, or be slightly more minimalistic if it's a reasonable option, avoid some of the things that I don't want and maybe get a slightly less result. And that's a very typical conversation. Some people go to the maximalistic side, some people go to the minimalistic side. And I think as long as you can tell people and be clear about what to expect one way or the other, when the time comes, yeah, if they got 80% of the result, they'll be happy because they understood that that's what they were signing up for. So,
Absolutely. And yeah, actually, I just came back from the big plastic surgery meeting this past weekend. And one of the things that I saw that I thought was super cool, and I've actually seen it on the market already, and I know the rep, is this device called Bridget's. And so what it is, and I'm speaking about it specifically for breast procedure, like breast lift, because what everybody always hates is that line down the middle. They don't want that. So what I saw a before and after that just blew my mind. And it was like her showing me her friend's result with using this Bridget. So what it
the
does is
little plastic,
it's the little plastic thing right at the midline. So it takes all of the pressure, all of the tension off the incision, and the incisions are healing beautifully, like such beautiful incisions. It makes me want to go back and do mine again and get another incision, but this time use the Bridgets.
you can do it. You can do it
Yeah.
if you already had it. You can kind of do that scar revision or relift and then use those again. Yeah, for sure.
Yeah, exactly. So if you're listening and you're afraid of that scar, if you're afraid of if those midline incisions, that lollipop scar, there are other things out there on the market other than scar creams and lasers and all of these things that you can do to minimize your scars. Because what I do know is if you decide to go with the lesser option, there might be a chance you come back and you end up doing the bigger surgery anyway.
Yes, that's absolutely true, and that's again something that I always communicate to patients is you can do this lesser option. My concern is after we're done, like I'll give you an example. Somebody needs a lift but just wants to implant, and you explain to them they're going to sit low and whatnot, and you say, look, my problem with this taking this approach is after we're said and done, they're going to sit too low. You're not going to like them. You're going to come back and tell me, fix them, please. And I'm going to tell you, you need a lift. Right. So instead of sparsing those out in like two different surgeries or just accepting that the patient doesn't want the scars and just doing it without explaining the consequences of that decision, uh, you're putting the patient at a disservice, really. And now you're doing a second surgery, which you probably don't want to do for a patient that's unhappy, that probably didn't want to do it anyway. And now the other thing is it creates kind of friction, right? A patient now feels that you did not do well by them, right? That you were the one that allowed her to get this surgery that you knew that she wouldn't be happy with, and now you are charging more for a second surgery, and they'll be upset. And even if you have a fantastic result, they still may finish that relationship and still kind of be like, I don't know if I go to him again, even though the result was great, but because he wasn't really quite clear about things and I felt kind of taken advantage of. And
Hmm.
we never want to have patients feel that way, right?
Exactly.
We want them to feel comfortable and respected, you know.
Exactly. So with that is you're still going to have to pay for that second surgery. So, and sometimes you end up paying more by having to separate the surgeries into two stages than just paying the for one price to do it all at the same time. So my girl, I always talk to my girl because I know what they're thinking. They're thinking about how much is this going to cost me? How am I going to do this? So if for my girls who are listening, if you're thinking about doing the breast procedure, go ahead and just do the whole shebang because you will be happier in the end. You won't spend as much if you do it all at once instead of separating it, and your result will look 100% better than going with the lesser procedure and not getting the full result that you want.
Yeah, it ties in really well with what you're saying is be careful with who you let operate on you and make sure you have qualified people, board certified plastic surgeons and keep an eye out for the cosmetic surgeons because a lot of times they aren't board certified plastic surgeons or plastic surgeons at all. But we have a phrase in plastic surgery, which I'm sure you've heard a million times before. Cheap plastic surgery can be very expensive, right? And that just comes into you try to do something cheap to save some money, and now your results are terrible, or you had a very terrible complication, and now you have a lot of expense, time off, time away from work, time away from family, trying to recover from these things. And then when you're finally recovered, now you have to spend a lot more money to fix an issue. And so, we understand that, cost is obviously important, but, good quality work it takes time,
It
and it
takes
takes
time.
time and a lot of training too to get there. So
And what I like to tell my girls is if the price sounds too good to be true, if it's like, wow, I can do it for that much, it's probably not a good thing, because especially in Florida where you're at, the chop shops are popping up in every corner, and the prices, there's a battle to get to the bottom of how cheap they can do it. And the person that suffers is the patient, but the patient doesn't realize it. And it's because there's corners being cut left and right in order to bring that cost as low as they can possibly
and
get
they
it.
have no clue what is going on behind the scenes, what they're actually doing to cut costs. You're absolutely right.
Exactly. So one of the things, just from my personal experience when I was a patient coordinator, and just from my phone calls that I get from listeners who call me from across the country, I hear a lot of capsular contracture happening with these facilities that charge $1,000 for a breast augmentation. And when I'm talking about what you guys don't see behind the scenes, and the cutting of the costs, is they're cutting the cost of things that have been innovated to help. For example, the Keller funnel. They don't use Keller funnels because you have to pay for them. And the Keller funnel, they use it to reduce the chance of capsular contracture. So those are the things that behind the scenes, y'all don't even know anything about that.
I will take it even one step further. As surgeons, and when we're in training, one of the basic premises that they always teach us is you have to handle tissues properly, right? You have to handle them delicately. If you're careful with the tissues, they'll heal well. If you're very aggressive with the tissues, they won't. And so probably one of the most expensive things about operating is how much time you spend in surgery, right? The charge per hour of OR supplies, anesthesia costs, and those kind of things is probably the most expensive thing. And so how do you cut costs? By being quick, right? And so if you can get a breast augmentation done in 20, 30 minutes, and you just go in there, make the incision, go make a pocket, pop an implant in, take a look, even if it's slightly bad, it's okay, we'll just massage it, whatever, later, we're done. That's how they save money. It sometimes may not even be, who knows, they may still use the color funnel, because what the color funnels cost compared to an hour of, or
And
even half an hour
yeah,
of anesthesia, is actually
a
minuscule,
fraction.
right?
Yeah.
It's a fraction. And so how do they do it? They work on volume, trying to cut time as much as possible. So how do you do that? You go quickly, you make incision, you go in, and so you're not being careful with the tissues. You're not being precise with how you're creating your pocket. You're not taking the time, for example, with the hybrid we were talking about, to do some liposuctions, look some fat transfer, sit the patient up, see if everything looks symmetric. Do I need to do a little bit more on one side or other? And doing those small little things, those details that matter in the long run,
The
right?
artistry.
The artistry, the artist part, right? Because there's a lot of engineering with measurements and stuff, but then that's the artistry portion of it. And not only that, a lot of the times, and this happens here in Florida, is as soon as you're done with a certain portion of the procedure, somebody else is doing the closure. And surgeons off to the next room, off to the races to get another one in quickly. And so when they're doing these simple breast aug that last them 30 minutes, they may get through 8 of them in a day, right? If I do 3 of my hybrid breast augmentations in a day, it's a pretty exhausting day for me, right? Because you're worried about things, you're looking at things, and I always tell patients, occasionally I get the comment, "Oh, this is a simple surgery for you." And I look at it and I say, yeah, some surgeries can be a little bit more complicated than the others, but if you care enough and you look enough at enough detail of your anatomy and your planning, No surgery is simple, right? There are always going to be small little things that if you're paying attention and you really want to get those elevated results, there's always going to be things you have to address. And if you ignore them, they're going to be a problem later on. And that's what really I think, maybe early on as a young surgeon, you don't realize it quite as much. But as you go and you do this more and more, you get that, get those cases under your belt and get that knowledge and experience under your belt. You start realizing what are these small, tiny pitfalls that nobody ever explained to you in training because, you just realize them on your own as you go. And so, yeah, it's very important time and you taking your time to talk to patients, to plan things, to do your surgery is incredibly important. And I think just people don't know that, and I wouldn't expect people to know it either. But it's very important.
Absolutely. So before I let you go, I have to ask you one question that we always ask all of our surgeons. Are you team drains or no drains?
No drains, no team, no drains. If I
What?
can,
For
no,
tummy
if
tucks? Wait, for tummy
no,
tucks.
oh, for tummy tucks, no, for tummy tucks, yes, drain. However, um, I will. Usually with tummy tucks, if they're large tummy tucks, two drains. If they're smaller tummy tucks, I'll try to put just one drain in there.
The
I
question
mean,
is for tummy tucks, not for breast.
this is for tummy, not for breast, not for breast. No, no, for breast, most of the time, no drains. For tummy tucks, yes, drains. I mean, I'll put it this way. I think there are a lot of people that do drainless tummy tucks, and read some stuff and seen some of the literature. I think the concern is that no matter how much you try, there's going to be some fluid accumulation. And so if you're not doing a drain, you're probably going to have that patient come in a couple of times throughout the week to drain them anyway with tapping them. And
Exactly.
it becomes a more practical thing for patients. Would you rather come in, every other day for the next week to get drained, or would you rather just have a drain and pull it out in a week? Most patients say just do the drain, and I get it. They're a necessary evil. They're annoying, but they're useful. They're useful. Yeah. So I'm team drains. Yeah, yeah. For tummy
Okay,
tucks, for
so
sure.
whoever's keeping score, whoever of my listeners is keeping score, we have another one for team drains. And just so you know, I think out of maybe 50 surgeons that I've had on, we've had maybe two who are team no drains. Everybody else is team drains.
You know what I would say to that? If it works for those two surgeons, if whatever they're doing works for them, then great. Let us know what you're doing. I bet most surgeons would love to not use drains. The problem with the tummy tucks, particularly if you're doing a lot of liposuction, just the amount of dead
Necessary.
space and fluid that you have is just you're going to accumulate fluid. It's so tough to manage that if you don't have a drain.
Yeah. So I'm team drains. So I 100% leave it in there, take it out when you're done, and you'll be done with it. It's a necessary nuisance for only a little 7 days, just give it a little bit of time. So I'm definitely team drains. If somebody who's listening wants to come see you, how could they find you?
So, very easy to find me. I think probably the easiest way is Instagram or just Googling. My practice's name is Naples Plastic Surgery. Very easy. I have an Instagram account which is Baccaro Plastics, Baccaro Plastics. And through there, you can actually message me directly. I can put you in touch with the office. I do a lot of telehealth consultations. I've had patients fly in from California, from Canada, from Chicago, like all over. And depending on the type of surgery, we can kind of arrange things for patients who are traveling. If not, if you're local, or relatively local, yeah, it's very easy to just come in for a consultation. I do telehealth and obviously inpatient consultations, and we just figure things out. We have a hotel nearby, which we have a little agreement with to try to get slightly lower rates if patients need to stay in a hotel. But if anything, it's a nice place to stay if you need to recover. So
Nice, nice. So, with that, you guys, I will be ending this episode on a wonderful note. And thank you so much for being on the show and educating us so much on breast procedures. Until the next time, I'll see y'all next week.
thank you so much for having me. Have a great day. Have a great weekend, and I'll see you next time.
Thinking about plastic surgery, but you don't know where to start? I've got you. With 18 years in the industry and experience working with top board certified plastic surgeons, I help women like you make informed and confident decisions. Whether you need help choosing a surgeon, planning your recovery, or understanding what to expect, I've got your back. Skip the guesswork and get expert guidance by booking a call with me today. That's a wrap for this episode of Big Butts No Lies. If you found this episode helpful, do me a favor and subscribe, leave a review, and share it with a friend who's considering plastic surgery. Your support helps more people get real, unbiased info they need. And if you're ready to take the next step in your surgery journey, I've got you covered. Book a consultation with me at bigbuttsnolies.com and let's create a plan to get you the results you've been dreaming of. Follow me on Instagram at Big Butts No Lies Podcast, on TikTok, and on YouTube for exclusive behind the scenes and more real talk about plastic surgery. Until next time, stay confident, stay informed, and remember, big butts don't lie.